Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This educational program, Chronic Hand Eczema, All Hands on Deck, is sponsored by Leo Pharma. We are joined by our host, Dr. Christopher Bunick, Associate Professor of Dermatology at Yale University in New Haven, Connecticut, and expert dermatologist Dr. Jonathan Silverberg, Associate Professor of Dermatology and Director of Clinical Research and Contact Dermatitis at the George Washington University School of Medicine and Health Sciences in Washington, D.C. Please note that the faculty speakers will reference slide content, which is available for download in the description section of this podcast episode and at livederm.org.
Welcome, listeners, to the latest LiveDerm educational program. I'm Dr. Christopher Bunick, Associate Professor of Dermatology and Translational Biomedicine at the Yale University School of Medicine. Today's episode, Chronic Hand Eczema, All Hands on Deck, is sponsored by Leo Pharma, and I'm joined by my colleague, Dr. Jonathan Silverberg, to discuss the differentiating features and emerging treatment options for patients with chronic hand eczema. Dr. Silverberg, thank you so much for joining us. Can you please introduce yourself for our listeners and audience?
Sure. Thanks, Chris. It's great to be here. I'm Jonathan Silverberg. I'm a professor of dermatology and director of clinical research and patch testing at the George Washington University School of Medicine in Washington, D.C.
All right. Well, we're going to dive right in. So, Jonathan, to start, what is chronic hand eczema, and why is education on this particular disease so important?
Yeah, so chronic hand eczema it's really a mixture. It's a broad sort of entity, which is essentially defined more by the fact that it's affecting the hands and its chronicity. The general consensus is that if it occurs for more than 3 months in a consecutive fashion, or if even less than that per episode, but relapses twice or more per year, that would fit under the appropriate definitions for chronic. And of course, it's the eczema affecting the hands. And as we'll see, it's a pretty broad bucket of disorders.
So chronic hand eczema is often described as a very heterogeneous, long-lasting, fluctuating inflammatory skin disease. What are some of the key signs and symptoms that patients experience that are suffering with chronic hand eczema?
Yeah, so similar to what we might think about with atopic eczema, we know itch is a big one. And we talk about itch in eczema, in atopic dermatitis in general, but on the hands, pain becomes a much, much bigger issue. So we've got this sort of almost equally weighted duality of symptoms between pain and itch. But of course, then there's the signs, right? The flaking, the cracking, the dryness, the bleeding, which can become a very big issue, swelling on the hands, all these open sores that happen, sometimes oozing, crusting. And then, of course, all the downstream impacts that all of those different features will have. And it's not to say that patients will have all of these at any moment in time, right? There can be sort of this up and down course, but it's something that throughout the course of the disease, almost all patients will pretty much have all of these signs and symptoms.
Yeah, I think you hit on a very important point, and that is that up and down, or the fluctuation in disease. So it can fluctuate in appearance and severity over time. And I know that I've had patients that come in and they're like, I swear, doctor, my hands are so much worse than this normally. Today happens to be a good day. And sometimes patients can be frustrated when they're not showing their worst when they arrive into the doctor's office because they're worried the clinician's not going to take them as seriously.
Yeah, absolutely. I mean, I think it's, I always jokingly say with patients, it's Murphy's Law. By the time they get in to see us, they're going to be clear. But I fully acknowledge that. And it's something that I learned a long time ago. When we are assessing patients in office, that's just a random moment in time when they happen to have been able to get in to see us. But that doesn't necessarily reflect what has been going on in their disease for the past 6 to 12 months or beyond. We really need to not, settle on just looking at the skin at that snapshot in time, but really trying to understand the patient's experience with it over the long haul.
Yeah, absolutely. I think that what we just heard about the signs and symptoms, it's important to understand the impact that they have, the burden they place on our patients. And if we take a look at this particular data slide, there's 4 key areas of burden on patients. So if we go from left to right, you got high socioeconomic burden that occurs in chronic hand eczema patients. This might be a high cost of sick leave, loss of productivity, loss of employment. Secondly, there's the impact on the patient's ability to work, especially if they involve wet work with their hands, or they have frequent exposure to irritants or allergens. Thirdly, it can impact patients' ability to perform domestic tasks such as around the house. Skin irritation from detergents or taking care of children can increase the risk of hand eczema. And lastly, it can severely impact daily life and quality of life. And in fact, it's been said that the quality of life of chronic hand eczema patients can be impacted or detrimental to the same impairment level of other serious chronic diseases. And I think that that's really important for clinicians to understand is when a chronic hand eczema comes into the dermatology office, their quality of life can be substantially impacted. So with that said, Jonathan, that there are 3 particular psychologic comorbidities that have been seen in hand eczema patients. Can you tell us a little bit more about those and why these are so important for us to understand as clinicians?
Sure. So probably the big 3 would be depression, anxiety, and then along with that, suicidal ideation, as we would expect. Often when there's a major burden of depression, there can be suicidal ideation, but sometimes they actually can run sort of independent of each other as well, where there may even be suicidal ideations, even in the absence of severe depression. And there are other mental health impacts that have been implicated in this disease, similar to other chronic dermatologic disorders, including, difficulties in terms of concentration, fatigue, substance abuse disorders, So this is something that's really impacting the emotional health of patients.
Yeah. And I think it's so important to ask about that burden and the psychologic health of patients. And it gives you an idea of why it's so important to have kind of new therapies that tackle chronic hand eczema. And so when we think about chronic hand eczema and how it presents in clinic, there can be up to at least 8 major ways clinically that it can present, where you can have erythema, you can have scaling, you can have lichenification, you can have edema. So I think, Jonathan, that's one of the side effects or I guess symptoms of chronic hand eczema that I don't see or I don't necessarily think of first off when I think of chronic hand eczema. But the swelling can impact, right, movement of the fingers or their ability to perform daily tasks.
Absolutely. And sometimes what patients will endorse is, especially when they have fissures on the distal parts of the fingers, but just closing their hands or trying to grip a steering wheel or a doorknob, the pain that comes with that, especially when the skin is dried out, is absolutely extraordinary. And each time they're opening and closing their hands, they'll start to bleed. And, so that is a major, major issue. But that is a large part because of that swelling, that stretch on the skin.
Yeah, I think in my patients, what I've experienced, you mentioned pain, right? Itch, but also pain is some of the big symptoms patients experience. And the patients that have those fissures seem to be the ones that really complain about the pain the most, although that may not be the only reason they have pain, but certainly the pain level of fissures, it can be off the charts.
Absolutely.
So other signs besides the erythema, scaling, lichenification, edema, hyperkeratosis, I think we've all encountered vesicles, the fissures, as Jonathan mentioned, and sometimes nail dystrophy. So even the nail plates themselves can be affected from the inflammation of the hand eczema. So with that said, Jonathan, we've really touched here on how it presents. But what's really interesting is that hand eczema can be classified sometimes by the etiology or how it looks. Can you walk us through a little bit about how we characterize or classify these hand eczema subtypes?
Yeah, so this is where it starts to get a little bit more complicated and arguably a little fuzzy. There's a lot of different potential etiologies for chronic hand eczema. I think we're all aware of the potential irritant exposures, irritant contact dermatitis, and that can trigger dermatitis even when there's no allergic sensitization per se. Then you have some patients who have allergic contact dermatitis where there is truly a sensitization to an allergen, and they may react not only on the hands, but really any part of the skin. There can also be protein contact dermatitis, which is more of what we would think of as contact urticaria. That's going to be usually to proteins. So, I have patients say, when they're cooking chicken, they touch the chicken, or they'll have reactions to latex or things like that. But then we know that, of course, hand eczema impacts patients with atopic dermatitis, even when there isn't this standalone component of irritancy or contact allergies. And in truth, these are not mutually exclusive. And we often have patients where they have a background history of atopic derm, but they're getting irritancy from frequent hand washing. And then it turns out they're also allergic to something in their soap or in their hand moisturizers or whatnot. So we have to really think multifactorially when working up patients. Now, the tricky part, of course, is it's also clinically a heterogeneous disease, as you illustrated just a few minutes ago. And, you have patients who have more of fissuring on the pulps, or you could have patients with more nummular lesions, or some patients more chronic vesicular hand eczema, some has more scaling, looks more psoriasiform. Many studies have tried to see, can you link up in any way that morphologic heterogeneity with the etiologic heterogeneity? And despite some really high quality efforts, unfortunately, they've all kind of struck out, meaning any of these morphologies can really be any of these etiologies, which means you have to think about all of them in clinical practice. You can't take shortcuts. You can't just make assumptions that it's all just maybe atopic dermatitis. You have to realize, well, there could still be a contact allergen or an irritant involved when assessing and managing patients.
Yeah, I think that's well said about the multifactorial nature and the ability to have mixed forms of these subtypes. And I think that's actually the exciting part of being the dermatologist, right? You see a chronic hand eczema patient, you have to play detective. It's not just handed to you on a silver platter what the diagnosis is, right? You may say chronic hand eczema, but we got to dive much deeper. And I think that's what we're learning, is there's so much more behind chronic hand eczema. And you spoke to this, all of this multifactorial nature. Well, it turns out that some of the science shows that there's distinct immune signatures behind some of these subtypes of chronic hand eczema. So, Jonathan, can you walk us through a little bit about the differences in the immune signature?
Yeah, so there's definitely some overlaps, but there's some distinct aspects as well. When we think about atopic dermatitis in general and hand eczema in patients with atopic dermatitis, we think about, predominantly more of the T helper 2 cytokine axis, plus or minus a role for T helper 22 pathways. Now, when we think about more irritant contact dermatitis, there's sort of a mixture, and it almost looks more like a psoriasis signature. We're seeing TNF alpha upregulated from keratinocyte disruption. We'll see a Th1 upregulation, Th17 upregulation. And then when we think about allergic contact dermatitis, we used to think the old board answer was it was all Th1, but now we recognize, well, some things skew Th1 or Th17, and other allergens may skew Th2, Th22. And so all of a sudden that became more complicated. And then there may even be additional roles for T helper 9 pathways and other things as well. So, and then on top of that, when you think about the protein contact dermatitis, now you're getting more into that urticarial axis, right? The IgE type 1 hypersensitivity. So all of these can overlap in patients, and it's something that when treating them, we kind of have to address some of this heterogeneity from a treatment perspective.
Well, I think that's a really, really important point. As you can see on the slide for the audience that has the slides available, you can see that Venn diagram where it overlaps in the middle, it could be any of these Th1, Th2, Th22, Th17 profiles. There can be a real overlap. And that speaks to the type of medicine that's needed to treat chronic hand eczema. And we're going to get more into kind of this idea of a topical novel pan-JAK inhibitor and its ability to hit all of these pathways and why it's so tailored for chronic hand eczema patients.
Absolutely.
So what about the common subtypes of chronic hand eczema? In this particular registry, Jonathan, these numbers don't add up to 100%. Why is that?
Well, I think as we've already sort of alluded to a few times, is that patients will have these overlaps. And so we can, and maybe not even at the exact same time, maybe on, in February when it's cold and dry, it may look more of this kind of hyperkeratotic, but then you get into the summertime, it may look more chronic vesicular. And sometimes at the exact same moment, we've got these mixed morphologies that are happening. So we have to recognize that, as they say, patients don't read the textbooks, and it's not always just one neat little pattern. It may be multiple. And there are nuances there in terms of how we need to think about, the type of moisturizers or the type of topicals, or, addressing some of the practical trigger avoidance strategies, which kind of relate a little bit to these different morphologies.
Yeah, I think that what's really, if you step back and think about it, is I'm the clinician seeing the patient. Based on this particular registry, 1 out of every 2 of my chronic hand eczema patients will have more than one subtype based on this particular registry. That goes back to what you said a slide ago, where you have to be on your toes. You can't just see a hand eczema patient and say, it's this, it's that, because the data says 1 out of 2 patients, there's going to be mixed subtypes.
Absolutely.
So just to sort of, I think this slide here that we're looking at really reemphasizes the points we've been making, that you have for driving hand eczema, you can have exogenous factors, irritants, allergens, pathogens. You can have endogenous factors, skin inflammation, skin barrier defects, but all together, they really represent the multifactorial nature of chronic hand eczema. And I think in particular, it's important to think about the interrelatedness of these particular drivers of the disease. So it's not just simply that you may have an irritation or an allergen, but the irritation and the allergen may be related, and there may be a cycle of the way these triggers impact chronic hand eczema. So Jonathan, can you walk us through a little bit about this cycle of triggers? Because I think this is really important for understanding some of why we see the kind of heterogeneity in the clinical presentation.
Absolutely. So, before I even sort of narrate this slide, I think I'll just give you, an anecdote to illustrate the point, which is patient has lifelong atopic dermatitis. Now in the workplace, they have to wash their hands a little more frequently. So they have the atopic component, maybe even had some hand involvement to begin with. But now they're getting exposed to irritancy, through an occupational or home setting. So now they have 2 things. Now, on top of all of that, because of frequent repetitive exposure to all kinds of personal care products, emollients, things that even we're prescribing to try to address the underlying hand eczema, now they may have picked up a contact allergy to lanolin in their moisturizer or some other ingredient that they're using in a day-to-day basis. So now all of a sudden they have the trifecta there, and you've got to address all of those. And so this is something that we see come up a lot. We have the impaired skin barrier, which is now going to allow for penetration of allergens, irritants, potential pathogens, etc. Now, those are going to trigger inflammation in the skin. And then that inflammation, will get more inflammation. You can get into this vicious cycle. And then on top of that, we have to add in the behavioral response to the itch. Now that's going to scratch, or the pain, the rubbing and scratching more, that's going to further impact the skin barrier. And all of a sudden we've got this feedback loop where barrier disruption is leading to inflammation, and inflammation is leading into barrier disruption, and then sprinkle the behavioral component on top. And all of a sudden, we've got this vicious cycle.
Yeah, I think it's really important to understand the cycle, because you really have to break it in order for the patient to improve. And we know from our treatment of atopic dermatitis in and of itself, especially with biologic therapies, that the studies that show that these therapies actually, when you take down the inflammation and the immune component, that it actually leads to barrier improvement, restoration of certain barrier proteins, et cetera, that are expressed in the epidermis. And I think that's really important. That connection is absolutely valid for chronic hand eczema as it is for atopic dermatitis. So how do we work up chronic hand eczema? There's currently no standardized guidelines in the United States for diagnosing and treating chronic hand eczema, but we do have from the European Union and Canadian guidelines some important steps to help us deal with these patients. So Jonathan, can you just walk us through how you approach a chronic hand eczema patient and we'll work them up?
Yeah, so I love the way you said it earlier. You got to put on your detective hat a little bit and dig in. I mean, the first thing is a good history, in terms of a history of present illness and family history is crucial. You want to understand a good amount about what they're getting exposed to on a day-to-day basis. For example, how frequently are they washing their hands, or what are they getting exposed to at work? Are there any occupational chemical exposures, et cetera? But you really want to drill down on the basics around how chronic is it? What's the disease course? Are they getting sort of shorter episodes that are resolving with treatment, or is it just more of this chronic endless course that never gets better? How they do with past treatments, and understanding, patients, they live with their skin all the time, so they often already have some sense of what their triggers might be. Not always, but sometimes they do. So you want to get a sense of that. And then for the physical exam, right? It's not just to get a sense of like how severe it is, but understand a little bit about the distribution, the morphology, the overall severity. That's going to give you a sense of how aggressive you need to be on treatment, what types of treatments you might be thinking about in terms of vehicles or triggers or emollients. And then, there's also the accessory role for things like skin patch testing, to a lesser extent, prick testing. In general, we're not a fan of doing biopsies because they're just really not that good on the hands in terms of differentiating between the different forms of dermatitis or even differentiating from psoriasis. But sometimes they have the role to rule out rarer disorders like cutaneous T-cell lymphoma or some other scenario that might be less common. And then certainly microbial tests you might think about if you're worried about scabies or if you're worried about, tinea manuum, certainly something you would have to think about as well. I certainly would encourage doing a scraping rather than a biopsy to find out those diagnoses. But, the accessory testing is just that. It's accessory. This should really be a clinical diagnosis. And by and large, we should be able to, a good clinician should be able to make this call on history and physical exam.
Yeah, I think I agree with what you said. I want to dive in on two components here. Let's first start with patch testing. What role, can you just talk a little bit more in detail about what role patch testing plays in your chronic hand eczema patients? And I want to give an example in my own clinic. I had a roughly 22-year-old female who was working in a florist shop and came in with chronic hand eczema. And in this particular instance, to be able to do patch testing was really helpful because we were able to identify parthenolide, a sesquiterpene lactone, which is known to be something that can drive allergic contact dermatitis in florists because it comes from plants. This was really helpful for us to be able to talk to the patient and be able to advise her on what may be triggering her chronic hand eczema. So do you have any anecdotes like that from your clinic?
I'm a patch tester, so I've got thousands. There's recently we published a manuscript looking at data from North American contact dermatitis group data, which is arguably some of the most authoritative, list of allergens and profile of contact dermatitis in hand eczema patients within North America. So it's definitely a big issue, and it's something that we need to think about on a regular basis. The International Eczema Council and the European guidelines have argued every patient, ideally with chronic hand eczema, should undergo patch testing. Now, maybe in a theoretical world, that is reasonable. I think there's just an access and resource limitation issue there. There's just not enough patch testers in the world to address all the hand eczema patients. But it illustrates the point of how important patch testing can be in these chronic hand eczema patients. So typically, of course, we'll try using prescription topicals and going somewhat conservatively beforehand first. Then if they get better with some mid-potency topical steroid or whatever, and they're doing fine, I'm not going to necessarily push patch testing. But if they're refractory to topicals, and I'm at that point where, we're starting to think about systemic, so we have to go to, additional non-steroidal agents, patients really are suffering and struggling, that's a patient who it's totally reasonable to think about patch testing.
Yeah, I agree with you. I'm a big patch tester for my chronic hand eczema patients. I've seen it helps some patients, like the florist that I described. The other thing that I wanted to talk about was the cutaneous biopsies, because you mentioned cutaneous T-cell lymphoma, and it turns out that happened in one of my patients, where I inherited a patient that had been treated for several years for chronic hand eczema, and none of the treatments were working, including systemic treatments, and the patient hadn't had a biopsy. So this is where I think for clinicians, if you have a patient that isn't responding to multiple therapies based on a pattern you think should be chronic hand eczema and should be responding, that patient that's sort of falling outside the bell-shaped curve, that's where a biopsy can be very helpful. And this patient actually had cutaneous T-cell lymphoma. And I definitely think that should be in the back of your mind when you have a patient saying, I have tried everything, this is going on for years. Getting that biopsy to just be sure of where you're at a histological level, I think could be very reassuring.
Absolutely.
So we sort of touched on this, but let's dive into it a little bit deeper. But there really is an important difference between chronic hand eczema caused by atopic dermatitis and that's not atopic dermatitis. So what are some of those differentiating features, John?
Yeah, so probably the one thing I mentioned, a lot of high quality studies try to match up the morphology with the etiology and didn't really have great success. But probably the one thing that stands out from all those studies is when there's predominantly dorsal hand involvement, that tends to be a little bit more skewed in favor of atopic dermatitis as the underlying cause, rather than other etiologies. That is by no means a hard and fast rule, but in general, dorsal hand may be more atopic hand eczema. Whereas when you see things like, chronic vesicular hand eczema, we tend to think, oh, wait, it's probably some kind of irritant or allergic component above and beyond. But it's look at the rest of the body too, right? You'll see if there's dermatitis or other lesions affecting other parts of the body. Get a sense of the morphology overall. Are there atopic comorbidities or not? Do you have to do any kind of IgE testing? Absolutely not. But sometimes it can be supportive to show a greater predilection for type 2 inflammation. But the non-atopic hand eczema is going to be more of everything else, essentially, right? And it's kind of the Wild West because it can look like atopic, it can look non-atopic. Sometimes you'll also have the involvement of the feet as well. Most of the time, patients will have involvement of hands alone or feet alone, but every once in a while, you'll get this, or I should say the other way around, hands alone, or to a lesser extent, hands and feet overlapping. The least common subset would be foot alone, but that is something that, even though we're talking about hands, we do need to think about the feet as well as sort of in this bucket. And, but we also have to think about is there a relevant history of, seasonality, exposure to different triggers, et cetera, and they would potentially can consider different testing around that. But a lot of the, more scientific stuff mentioned on the slide, like flagrant null mutations or Th2 signatures, we don't have access to any of this stuff in clinical practice. Even in a research setting, we don't really have access to this. So as much as we know it's kind of true and differentiates them, as clinicians in the trenches, we're left with really focusing on the clinical aspects.
And to your point, I think that's where looking at the rest of the body, looking for other signs of atopic dermatitis in the classic morphology and distribution would be very important. And also that atopy family history or personal history, right? The asthma and allergic rhinitis, I think sometimes can be a clue whether they have that atopic diathesis.
Absolutely.
So just to sort of kind of review this chronic hand eczema and differentiation of atopic dermatitis, we've sort of talked about how chronic hand eczema is this complex disease with overlap in the pathophysiology with atopic dermatitis, particularly atopic hand eczema. Oftentimes, the chronic hand eczema can be limited to hands and wrists, but as we just said, atopic dermatitis can affect different parts of the body. But what's really important, now that we sort of move over into the science part, that the JAK-STAT pathway plays a key role in both of these conditions, right? So both atopic dermatitis and chronic hand eczema are characterized by inflammation and skin barrier dysfunction. And at the root of that can be aberrant JAK-STAT pathway signaling. We know that both atopic dermatitis and atopic hand eczema can have a Th2 immune profile. And as we sort of mentioned, some chronic hand eczema subtypes are immunologically distinct from AD. And we sort of talked about the involvement of Th1, Th17 pathways as well. So targeting a type 2 immune response may not necessarily treat all chronic hand eczema subtypes. So when it comes to treatment, there actually are no current treatments that are FDA approved for moderate to severe chronic hand eczema. So saying that, Jonathan, what are the current treatment options for chronic hand eczema?
Yeah, so it depends really where you are in the world. But in the US, we basically have nothing to date. And that has been a big frustration for us in clinical practice. Technically, we have topical steroids because there's such a broad label, even though they weren't actually studied in hand eczema, we have officially approval there. But we have literally nothing else. And that is a big issue. We have a little more recently, we've gotten a label update for dupilumab, which is a biologic inhibiting the signaling of interleukin 4 and 13. That is not actually for the broad sort of chronic hand eczema as a diagnosis, but it's specifically for hand involvement in patients with atopic derm. But that is certainly an important addition to our toolbox for consideration, but we still have actually nothing officially approved for the totality of chronic hand eczema. So we definitely have challenges, and it's a limited toolbox in that respect. But we cycle through the topicals. We're going off label a lot for sure, where we're reaching to technically things that might be on label in atopic dermatitis or in psoriasis, and maybe even were used in the hand involvement in those disorders. But we may be venturing into a little bit of off-label waters if we're treating an allergic or irritant contact dermatitis with some of these drugs. But that's essentially where we go with it. So we have data for years now on topical calcineurin inhibitors. More recently, there's some data in the literature around topical PDE4 inhibitors as well being potentially used. But again, all of this is really within that off-label realm. One thing that's very clear, though, is that the topical steroids, as well or as not well as they may work on the rest of the body, they tend to work even less well on the hands. And that's something that they just don't absorb well. You need to go more potent. And you often just run into the real cycle of inadequate efficacy and all the steroid side effects, right? Because the patients often need to use these chronically, and they're going to get thinning of the skin because of it. They'll notice the veins become more prominent. They get easy skin tears, fragility, etc., discoloring, and the patients will. I find, like most of my patients, tolerate topical steroids reasonably well in different parts of the body, but often when I get those complaints, it's on the hands with that chronic use, and so there's really a big need for us to have more non-steroidal options. And again, we have things we can turn to off-label, but with limited data and in truth, with limited success to date.
Yeah, and Jonathan, 3 out of 4 patients in one study have reported that they would prefer a steroid-free topical therapy if available. And I think that mirrors what I see in my clinic. Patients reluctantly will take steroids, but a lot of them are excited to have a non-steroidal option if it were available. I think that's what I've seen in my patients.
Absolutely. And I often say this to patients, say, look, I'm not married to using topical steroids. I'm prescribing them here only because they're cheap and accessible. The reality is I look forward to a day when I never have to prescribe a topical steroid again. And I mean that. It's just the complexity of having to walk through how to stop it, how to do maintenance. it's just so much cleaner and easier if you've got a good non-steroidal that you can say, look, use it when you need it and not when you don't, and it simplifies things.
And one other point I'll make is that I'll often have a patient that I'll be seeing for the first time, and they've been treated for chronic hand eczema before, and they've maybe for the last year been using the same topical steroid for a period of time. And they come to me and they say, well, it worked at first, but my steroid's not working anymore. And remember that steroids have been associated with tachyphylaxis. And I've had many patients that have come in with that story where their steroids worked initially and then they just don't work anymore. Same steroid, same medicine, same way the patients have been applying it. And I think that that story in and of itself is something that we probably hear a lot in the dermatology office. And having therapies that are able to get around that, I think would be really helpful for the patients. So that's sort of getting into the unmet medical needs of chronic hand eczema patients. And Jonathan, we need something that's efficacious. We need something that's well tolerated. I think patients have spoken. 3 out of 4 want something that's non-steroidal. And we want something that's developed specifically to really target that heterogeneity of chronic hand eczema and really provide long-term disease control across all the different subtypes. And so with that said, what are some of the current topical therapy challenges to obtaining these goals of these unmet medical needs?
Yes, I mean, I alluded to some of these already. I think the biggest challenge, we have with the topical steroids is we know we're never going to be able to use it every day forever in a patient who might need to use something every day forever, or maybe not every day forever, right? But multiple times a week for an extended period of time. And so what ends up happening is we say, okay, use it for, like if you ever look in any of the EHRs, the standard boilerplate language for how to use a topical steroid is use it sparingly for 2 weeks and stop. Okay, and they did, and they got better. And then what happens? They stopped and it came right back. And the challenge is so now what, right? So it's a big issue of how do we keep them clear? They stop the topical steroids, can come roaring right back again. There's often the topical steroids are just not enough potency in the face of ongoing exposures to their triggers, like, ongoing irritant exposures or allergen exposures. And then the risk also is, well, okay, maybe they don't stop. Maybe they keep going every day for 3 months, 4 months. Well, now they're going to get the steroid side effects. And so that becomes just as much of a problem on the other side. Maybe officially the itch and the dermatitis are better, but they may have caused permanent harm in terms of atrophy. And then we mentioned, right, there's just this limitation of not having any approved, non-steroidals to work with. Again, we turn to things off-label with variable efficacy, not well studied, particularly in the hands. We don't have great data. And we don't even have great access. So this is something that definitely is an important issue that needs to be, a gap that needs to be filled. Some patients do require systemics. It would be great if we actually had topicals that worked as well as systemics, though. And that is also something that we just don't have right now.
Yeah, and Jonathan, there are some other options that are used by clinicians. Oral retinoids are certainly something that have been evaluated in severe chronic hand eczema, patients that aren't responding to these topical corticosteroids that are very potent. And phototherapy, kind of pre-COVID era, I would actually use a lot of hand-foot phototherapy for patients in my clinic. And for whatever reason, post-COVID, we no longer have phototherapy in my office, but phototherapy is something that I think still gets used quite a bit. What about in your clinic?
For sure. Phototherapy can be a very good option for patients. I will say, look, you have to know the limitations of phototherapy. When you have patients who have more moderate disease, it can be, in a sense, the magic bullet. But when you get to more severe disease, it's just often not enough. But you also have to set realistic expectations. It takes long. Phototherapy, because we use typically narrowband UVB in the US and in different parts of Western Europe, et cetera. And that's not a fast modality, right? So you really I sometimes a patient say, I used it for 2 weeks and then it didn't work. I stopped. It's like, you don't even get to an effective dose until like 4 weeks. So set realistic expectations, but you also have to know it's just not for everyone. caregivers, patients who travel far for work or traveling often. They don't have the schedule to be able to keep up with this kind of in-office treatment. And it's sometimes means traveling long distances, heavy copays. And then on top of that, like, we have zero data on home phototherapy, on the safety, on the efficacy. So we are, in a sense, flying a little blinded to use home treatments, and there's definitely risk. But for the in-office, we have some good data, but there's a lot of logistic limitations for patients.
Right. And I agree. Those logistic limitations are exactly why we need a topical novel pan-JAK inhibitor that's going to cover the gamut of chronic hand eczema subtypes. Not only is it going to work better, it is going to significantly relieve the burden of patients having to come to the office for phototherapy for that particular modality. And obviously, we've talked about why it's advantageous over the steroids. Building on that, the JAK inhibitor component, what we're looking at on this slide is a bunch of different cytokines that all signal through transmembrane receptors connected to the JAK-STAT signaling pathway. And I think that what this slide is really illustrating, Jonathan, is what we were saying is that the JAK-STAT signaling, depending on which underlying kind of type of immunity and inflammation is playing a role in driving the chronic hand eczema, the truth is that a lot of it goes through JAK-STAT signaling. And so from a purely scientific standpoint, developing a pan-JAK inhibitor is actually a really good idea for treating these different subtypes of chronic hand eczema. Would you agree with that?
Absolutely. It's, we're right now in a scenario where, like, we have either, in a sense, all or nothing, right? When we use topical steroids, we're kind of bombing the entire immune system, and then we don't have anything else to work with. But as we have learned more and more about the pathogenesis of the disease, albeit heterogeneous, we do have an opportunity to potentially go more targeted and address those pathways. Now, based on the heterogeneity, it's probably not going to be a single cytokine pathway as the perfect magic bullet for this disease. But if we could inhibit the signaling of all of those crucial pathways, right, there's a real rationale for that. And that's where a pan-JAK inhibitor is going to be broader, but still less broad than when you're using topical steroids and wouldn't come with the steroid side effects.
Absolutely. And I think that dermatologists are becoming more and more comfortable with concepts of JAK inhibitors, particularly from the oral use in atopic dermatitis, as well as TYK2 inhibitor use in psoriasis. And I think as well, obviously, topical JAK inhibitor for atopic dermatitis. And so I think that having a pan-JAK topical therapy that has negligible systemic absorption is a very welcome addition to being able to treat chronic hand eczema. So with that said, what about some clinical data of a topical novel pan-JAK inhibitor? Can you sort of tell us how it's working in severe chronic hand eczema?
Yeah, so we have seen some pretty impressive results so far in patients with really essentially all severities of hand eczema, but even going into the patients with severe disease. We've seen improvements in terms of a variety of different lesional sign scores, like the HEXI, which is a weighted average of severity and extent of lesions on the hands. We've seen improvements in terms of the IGA treatment success, which is like the FDA's preferred outcome measure for clinical signs for a drug. Improvements in quality of life, improvements in terms of safety even. There was even a head-to-head study of a topical pan-JAK inhibitor against oral alitretinoin. And we didn't talk about that too much because we don't have that approved in the US. But oral alitretinoin has been sort of the go-to systemic therapy in Europe and in those locales where it's available. And so when you have a topical that can perform as well or better, in this case, better, more effective and safer than a systemic therapy, that's pretty darn impressive. But we've seen improvements in all the different symptoms and a variety of different post-hoc analyses looking at secondary outcomes, et cetera, all of showing in totality that a topical pan-JAK inhibitor can really work well in chronic hand eczema.
Yeah, so I want to sort of touch on a point you just made that we see really, really good results in the IGA scores, as well as the quality of life indexes. And I think that's really important because this is synergistic with what we're observing in the atopic dermatitis field itself. And what I mean by that is, let's think about the aiming high in eczema and atopic dermatitis recommendations, which are trying to achieve in atopic dermatitis this minimal disease activity. And they call for, Jonathan, really, it's not just the clinician's assessment of, the skin lesions are resolved, but it's also those symptoms, particularly in chronic hand eczema, that would be itch and pain. And so when we think about chronic hand eczema and we think about this goal of minimal disease activity, which is really the goal now in atopic dermatitis, right? Achieving EASI 90 and itch NRS of 0 or 1, that same concept or principle is what I'm seeing with this topical novel pan-JAK inhibitor. It is clearing the skin lesions. It is getting you to IGA 0 or 1. And it has the ability to improve quality of life, reduce that itch, reduce that pain. And I think that having this synergy and the skin clearance and symptom relief, it sort of mirrors what's happening in the atopic dermatitis field itself for chronic hand eczema. And I think that is why a topical novel pan-JAK inhibitor with negligible systemic absorption is so critical. It can achieve this minimal disease activity. And I think that sets it apart from all the other therapies that we were just discussing, which are actually not even approved for chronic hand eczema. Let me ask you one final question, Jonathan. How many chronic hand eczema patients a day do you see?
Well, I'm biased because I'm a patch tester. But I would say in any given clinic, I don't know. I'd say at least 3 a day. At least. And on my patch testing days, 30%, maybe up to 40% of my patch testing patients are patients who have either chronic hand eczema by itself or in combination with other, lesional localizations. But it's super, super common and a super frustrating and challenging entity in clinical practice.
Yeah, I agree. I see probably 2 to 3 chronic hand eczema patients a day as well. And I bet you that most of our dermatology providers are seeing the same. That speaks to the volume of patients that have an unmet need and why this field is so important to pay attention to. And certainly we're all looking forward to the innovation that's coming. So thank you again, Dr. Silverberg, for joining me to discuss this incredibly important topic on chronic hand eczema. Listeners, for more resources and to stay connected with updates for all things chronic hand eczema, please visit the LiveDerm website and stay tuned for future podcast episodes on Derm Docs. Thank you so much.
Stay tuned for future episodes on Derm Docs, powered by LiveDerm. Thank you.